All right, good evening, everyone, and thank you for joining us for tonight's Woo You event. Tonight, we are with the one and only Dr. Jim Hoffman, and he is back to speak with us on when to use corneal GP lenses for irregular corneal cases. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Bausch& Lomb for exhibiting at this event. We'll get to hear from them at the end of this presentation, so please be sure to attend. We are really thankful for these sponsors to be able to make us, to allow us to have free CE, so please be sure to join and see what they have to offer. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, you can fill out the survey link that will be in the chat, and it'll also be there when the webinar ends. CE certificates will be emailed to you and sent to ARBO with your OE tracker numbers, and you should receive those CE certificates within about 4 weeks. We'll also have a QR code at the end of the presentation where you can scan through your OE tracker app to get your credit instantly. If you can ask questions in the chat or the Q&A towards the bottom, we will answer questions as they come for some of the cases that Dr. Hoffman is going to go through, and then towards the end of the presentation for anything that we've missed. You can find the Q&A and chat feature either at the top for the Q&A on your phone or under the 3 dots under More. So I am super excited to introduce our speaker for tonight. Dr. Jim Hoffman is a senior partner of a 6-doctor practice that is located in Orange Park, Florida, which is a suburb of Jacksonville. And alongside with his wife, Dr. Karen Hoffman, he leads 2 innovative offices that have delivered comprehensive primary and specialty eye care to the community for over 50 years. A summa cum laude graduate of the University of Houston College of Optometry, Dr. Hoffman's training emphasized in specialty contact lenses, which is a focus that continues to define his career and his frequent speaking and educating in this realm of optometry, as we get to hear tonight. Dr. Hoffman is a fellow of the American Academy of Optometry and an active member of both the AOA and the Florida Optometric Association, where he has served on the legislative committee and as past membership chair. Outside of optometry, he volunteers for his church and the Rotary Club of Orange Park, which has honored him as the Citizen of the Year in 2008. Here are his financial disclosures, all of which have been mitigated. And I will have you take it away from here.
Thank you, Ariel. I appreciate it so much. Good evening, everybody. Welcome to Wednesday night at Woo. So glad you all are here with us. Let me get this set up so we got it going the right way. And I am so happy you're here. Corneal gas perm lenses to me are such an important part of what we do that we can learn together. We can help our patients and do all the right things for all of us. And I mean that sincerely. Corneal gas perm lenses originally started out as hard lenses. They were PMMA, polymethyl methacrylate. And so now we've got lenses that are healthier, but provide so much more for our patients. We're going to review the prescribing of corneal gas perm lenses for those patients with irregular astigmatism. That's sometimes the frustration of our day. The proper fitting techniques will be explained for various conditions that cause those irregular astigmatism problems. And of course, our objectives, we want to discuss these different corneal conditions that create irregular astigmatism. The more we know about the cornea and what the shape and what the condition is, the more we can understand the anatomy of how we can have a lens to fit the patient. We're going to discuss those fitting philosophies and techniques for different conditions that you will see, I promise. And then, of course, we've got to talk about how do we make the lens to make it work like it's supposed to. What materials work great? How do we clean and clear the lens? Because rigid corneal lenses are so different than what we deal with in the soft lens realm. And so, as Ariel said, I do consult with a couple companies. I've got no financial interest in anything presented in this lecture, and I appreciate you all being here. So, regular corneal astigmatism. we know what astigmatism is. 67% of people have astigmatism. And so when the corneal curvature varies along two major meridians, and that they have to be perpendicular or mostly perpendicular to each other, then we know this person has corneal astigmatism. If we scope them, if the refractor gets to work with it, they can literally see those two focuses and allow the light to land on the retina correctly. So, of course, we correct these with cylindrical lenses. And how do we do that? If we're doing regular corneal astigmatism, obviously, we can do that with glasses. And that's how many of us start. That's how us give those patients that extra sharp vision. We do the spherical first, then we do the axis, and then we do the actual lens power to make sure they can see. If they don't see 20/20, then we start asking more questions. We obviously can do that with gas permeable contact lenses. Many of those lenses can use a spherical base curve, as long as they don't have more than 2.5 diopters of corneal curvature change between those two major meridians. If you try to fit a spherical base curve on those patients, then you're going to see a fluorescein pattern that shows you it's not centered, it's moving along that steepest meridian, and we end up with trouble. So a toric base curve is often used, especially we get into the 3, 4, 450 diopter corneas. A bitoric lens has back surface sphericity to correct the toric cornea, but then once that's neutralized the cornea, now we've got to do front surface sphericity to correct the induced astigmatism. What about front surface toric? Well, many times we'll put a spherical lens on thinking we've got all the cornea taken care of, and lo and behold, the corneal astigmatism is taken care of, but not the rest of it. So now we've got some type of astigmatism within the lens, within the optical system, and then a front toric lens with the prism ballast works terrific. And of course, multifocal lenses with corneal gas perm lenses work very, very well when you have regular corneal astigmatism. Not as comfortable for patients who have irregular corneal astigmatism. We'll talk about that a little bit later. And then, of course, soft contact lenses. There was a time when soft contact lenses were never able to correct regular corneal astigmatism. They just weren't that good. The 20 happy didn't come from LASIK surgeons. It came from practitioners trying to fit a regular corneal astigmatism patient with a soft toric lens. They just didn't stay, they weren't stable, they weren't clear. And so for those patients, I would oftentimes tell my patients, this is the best you can see with a soft lens. They don't make the lenses for you. We're going to correct this with a corneal gas perm lens so that you can see the difference. So if that's regular, then what the heck is irregular? Well, obviously, irregular astigmatism creates the kind of blur that patients will continue to complain about until we figure it out and explain it to them. So remember, it's diagnosed with topography where the dioptric asymmetry of the axes shows up, or in the technical terms, it has non-orthogonal astigmatism. The major corneal meridians basically are not perpendicular to each other. And you will see this with a retinoscope. You'll see that scissors reflex, you know something's going on. In the old days, keratometry, we would see mires that were distorted and not lined up, and no matter how we tried to turn it. And so those patients that have irregular corneal astigmatism are many times the ones that we tried to correct with glasses, but they complain of blur and monocular diplopia. Yes, monocular diplopia. And we often ask them, these are the ones where you get to do an RX check once, twice, 3 times. You have a new patient who says, I went to a doctor and I got glasses. I really couldn't see out of them. I kept going back. And at that point, you're starting to think, well, why not? We're all pretty good at doing glasses. So what's going on? And those are the ones you want to investigate a little bit further, try to figure out what's going on. Can you use a soft contact lens, a toric lens on these patients? You can. And don't be afraid to give that option a try. Many times we've helped patients when they didn't have an extreme amount, but enough that the lens took care of what they needed and gave them the vision they were looking for. Of course, spherical gas perm lenses we're going to talk about today are great for mild irregularities. Those irregularities where the person's just getting started with their condition, they're having a blur, and we're going to use these lenses to try and help the patient be able to see. However, remember, we need to tell the patient these are special lenses. They're not created until we create them. We want this to understand that these lenses are designed for you, for your specific eye condition. As part of that, we actually show them the lens, let them see it's rigid. Feel it. We never call it hard. We always talk about being rigid. The advantage of the rigid is it allows that lens to correct your vision unlike any other way we can do it. We do talk about if it's rigid, your eyelids are going to feel this. And so we're going to give you suggestions on how we can improve the comfort and ease you into understanding how well these lenses can perform. Vision's got to be the driving factor. If you see better with these, if you understand how clear your vision is, the rest of it's going to follow right along. Many times telling patients doesn't work. We've got to put it in their eye and let them see. And I always use ophthalmos for the patient to see how well they can see. It eliminates some of the tearing that we know is going to happen when they put a brand new gas perm lens in. And so a drop of ophthalmos in each eye, we put the lenses in and quick over refraction, show them how clear things can be. My staff knows if we're going to do an RGP instruction and removal training, it's going to take longer. We have to be more patient. We're asking that patient to put a rigid lens in their eye. And so that extra time on insertion and removal will help the patient succeed. You can't just rush through that. Many times it's patients who are staff members who wear gas perm lenses themselves, or if not, they've at least experienced it. So they've actually understood what the patient's going through. Helps our patients realize I can do this because Mary's had the chance to do it, or Bob has had the chance to do it as well. And so, what are the conditions that create irregular astigmatism? Many of you know these, so maybe this is a reminder, but let's talk about those. First, we talk about the epithelial and stromal irregularities. What's going on in the front of the eye to create this distortion, this aberration, and this non-orthogonal astigmatism, where it doesn't line up like it's supposed to. The first one, of course, is epithelial membrane dystrophy, EBMD, map dot dystrophy, Coogan's dystrophy. And all those are used interchangeably, but they're all dystrophies on the epithelium on the front of the eye, extended to the stroma, and it's definitely going to create that kind of blur that patients are going to be able to notice. Many times, I guess one of my frustrations is why do we try to refract them before we look at the eye? And so a new patient, I'm refracting them, something seems off. And it wasn't until I show with the keratometer that I'm like, the slit lamp, I'm like, wow, of course they can't see. They've got this condition that's affecting their vision. We love to get herpes simplex treated quickly and easily. Patients don't always do that. And when they don't, if they have scarring from herpes simplex keratitis, it's significant. It's deep. It affects the corneal surface, and it's going to affect how well they see. Of course, healed ulcers never have a corneal shape that's round again. Now it's irregular, and that residual scarring creates problems. Many of these people were wearing contacts before. They want to wear contacts again, but they can't go back to what they were wearing before because it's not going to correct the vision the way that they expect. And so we tell them now your eye requires something more rigid to create a new curvature for you to see with. Corneal trauma, referrals from corneal specialists, they've done their job. The patient's not able to see well. So corneal trauma is a wonderful time, a wonderful way to use a corneal gas perm lens to help those patients over what they've been doing. And of course, grafts. Corneal grafts are doing less. We're doing less and less of those now, thank God, because we've got now corneal cross-linking. But corneal grafts are still a successful way to use this technology called a rigid gas perm to try to help them out. Of course, post-LASIK, PRK and RK, if they're not seeing well and you do topography, you'll know why. You'll be able to tell that that distortion can't be corrected with any other way except some type of rigid lens. And that's where a corneal gas perm gives us the biggest help. So all of these epithelial and stromal irregularities are the type of patients that we find corneal gas perm lenses to be of benefit. Well, what about other corneal conditions creating that? Oh, so what about degenerations and ectasias? We deal with these in our practice daily. Salzmann's nodular degeneration is definitely going to give that cornea a surface that the patient can't see as clear as they like to be able to see. What about Turing's marginal degeneration? I have patients who've been told you can't wear contact lenses. Your corneal shape is too unusual. And I tell them that's not true, but we've got to make the lens the right size and the right shape to make sure you're able to see. Pellucid marginal degeneration, and I call that a hider of astigmatism. We correct that many times with glasses until all of a sudden they're not working well. And those kissing butterflies, the shape of the cornea, tells us how much blur the patient has. If you put a corneal gas perm lens on these patients, they're going to say, "Oh my goodness, I haven't seen like this in a long time." Of course, I call it the Mac Daddy keratoconus, which is progressive, as these other conditions are, but keratoconus, as you know, creates the largest amount of distortion. I fit keratoconic patients frequently when they're young in keratoconus. And then, of course, we know that there are times when this is not going to work. And we'll talk about when that is too. And of course, post-surgical ectasia. I'd love to tell you that that doesn't happen, but in those patients where we had no idea something like this would go forward, now we're literally seeing the cornea do exactly what you see in the bottom corner. We're now seeing that cornea doing exactly what keratoconus would have done before, and yet they didn't have keratoconus. They just wanted to have their vision corrected. And so knowing that that patient has that same shape, that's a little hint as to how we're going to fit those patients and make them see. And so how do we select patients for corneal gas perms, not some other modality? Well, the ideal candidate needs to be one who has stable corneal health. Even though we have these corneal conditions and we've got ectasias, dystrophies, you want to make sure it's stable. You want to make sure you've got a good manual dexterity, whether it be a young person, and we fit very young people in corneal gas perms because they're easier to put in and out. Make sure that they've got the ability to do that. Our seniors, the same way. We frequently have patients in their 70s and 80s still wearing corneal gas perms, but we won't know that arthritis and manipulation is important. So we want them to show us, yes, I can do this. And of course, motivation. We want the patient to be motivated and understand that cleaning these lenses is critical. These are not daily wear lenses. You don't throw them away. And that's a benefit. They last longer. I love that. But it also means we got to take good care of them, give them the right products, and make sure they're doing it the right way. So when do we not want to do this? Well, obviously, if they've got an active ocular disease, we're going to have to wait. We're not going to put their eye at risk if they're inflamed. We're going to be careful. What about poor film quality? Obviously, you're going to use fluorescein to evaluate the fit. You're already opened that strip. Why don't you put that in there before you put the contact lens on? We do. If you've got staining already, you're not a good candidate to put something on the cornea. And of course, if the patient themselves thinks, I don't think I can wear these lenses, they've got their own ideas about what contacts should be, then obviously patient selection, they themselves will take themselves out of wearing these contact lenses. So what are the advantages of corneal gas perm lenses over scleral lenses? Karen saw this and she said, I don't agree with any of that stuff. I said, yes, you do. So Karen's our scleral lady, my wife. And so let's talk about that. When I put that optane in, put the contact on, I have a fit and a refraction within minutes because it settles faster. The evaluation of lens can be handled much quicker. The overall fitting process doesn't take as long. We like to use diagnostic lens fitting. Yes, I know it can be done empirically, but I think giving the patient an opportunity to understand what the lens is like. So having a fitting set in the office, I believe is critical. And so depending on what type of patients you're working with will depend on what type of fitting set you want to try and get. And if it's just spherical lenses to start with, that's fine. Use that. You don't have to get anything that's too big, too large, and you don't have to get keratoconic lenses yet. Just know that you've got to have something in the office to have a chance to see how the lens settles, evaluate it, and get a good refraction. There's less fluid management. You don't have to worry about scleral fill. You don't have to worry about non-preserved saline in the bowl of a scleral lens. That's not necessary. So patients enjoy the fact that they can travel with very little fluid determination of what they got to take with them. It's easier to insert and remove. Trust me, it's easier to insert and remove. It really is. And so for patients who are struggling with any other lens, even a soft lens, they're easier. Patients who get these lenses say, they hop right on my eye. I said, right. Soft lenses don't. They hang on your finger. Scleral lenses, you got to make sure you've got the right inserter looking down full of fluid. It's better for patients with tight lids or small apertures. we'll show patients those large scleral lens, and they'll look at us and say, "There's no way I can get that in my eye." Well, obviously, a corneal gas perm lens, a 9.5, a 9.6, 10.0, be much easier to insert. Less expensive, easier to replace. That's kind of the elephant in the room for some of our scleral patients. If insurance doesn't cover it and they're not comfortable with the expense and the follow-up, then obviously a corneal gas perm lens can give them many of the benefits without some of the expense worries that they would have to try and deal with. Because they're a smaller size, we're able to avoid corneal and conjunctival irregularities. And our corneal specialists frequently send patients with tubes and blebs, and they say, do not touch, do not bother, do not make my glaucoma surgery fail. And right, okay, we'll make sure we do that. So with these lenses, we can assure the fit not to interfere with what's going on with their eye. Better oxygen transmission to the cornea. We know with sclerals that the lens covers a large part of the eye, with tears being the number one way the cornea gets oxygen. Having tears pump under and around the gas perm lens, it's got better transmission to the cornea. So, what are the attributes? Tell me about gas perm lenses if you're actually trying to fit a patient. Well, number one, not one design fits everybody. So please understand that every patient's individual, and they're going to have to have that special attention from you to make sure it works. Why do they work? Well, they mask irregularities with the tear lens between the lens and the cornea, since the tear lens can neutralize 90% of the irregular astigmatism. It literally creates a lens that neutralizes that error in the eye. Because the tears in the cornea have the same index of refraction, I frequently tell patients that these lenses help diminish some of the blur or aberrations. It actually is an optical Oreo cookie. The cornea, the tears, and the lens now form this new optical medium. And now the light doesn't even see your corneal irregularity. It doesn't even know that you've got this irregular cornea from a corneal dystrophy. We do use high DK over T materials. We definitely want to make sure we've got the best oxygen coming through to the lens. Start with the size. Dr. Quinn last week was 100% right. And we don't start with the base curve. We want to see what size works. And we'll talk about how we determine that tonight. We want to know what the base curve is for proper touch. That's what fluorescein is. And we're using fluorescein now more than ever with sclerals, and we've always used them with gas perms. You get really good at determining a fluorescein pattern with gas perm lenses. We want lenses at center. Decenter lenses you don't see well, and they certainly aren't good for the corneal scleral junction. Photography. Now with our iPhones, we can certainly take pictures through the eyepiece of the slit lamp and have the ability to literally take a picture of the lens on eye so that you can look at it later and see what's going on. Take a video of it blinking on the cornea, and that's incredibly helpful. And then, of course, remember what the thickness is of the center, what the thickness of the edge will make a big difference. Those things matter when the patient's wearing the lens. So what's the process? We'll start with a good ocular health examination. You want to be sure you know what the cornea's got going on. A good refraction. You want to know what their best vision is prior to putting the lens in, so you can say to a patient, I said to one yesterday, I said, here's what you see with your glasses. Let me show you better, better, better. Here's what you see with your gas perm lenses. They're like, wow. I'm like, I know these lenses are working for you. Don't forget to record the pupil size. I promise you'll need that at some point. So put that down at the initial evaluation. You want to know what the vertical fissure width is. You want to know how much room you've got to use an intropalpebral or a tucked under the lid position. Look at those conjunctival abnormalities. Your patient will never look at their eyes more than when they're wearing a corneal gas perm lens. And if you don't record that they've got a pinguicula before you start, the patient won't come back and say, what is that spot on my eye towards my nose? So record those, because patients will ask you and say, yeah, it was there before we started. Remember, I wrote it down on my chart. Look at the lid. Any ptosis, anything that's causing that lid to flop dermatoglacis, and of course, lag. If those things are happening, record them ahead of time. So if the patient comes and says, how come my lid's drooping? You can say, well, ma'am, that was there before. The lenses did not cause that. And obviously, we want to know what their internal ocular health is. Tell me if you've got glaucoma, you've taken drops for that. What other surgeries have you had? Obviously, retinal conditions. You want to know how that patient's done up to the time that you start using these lenses to help them out. And so, how do we evaluate the cornea? The most sensitive part of the eye, remember, it's got 72,000 nerves, and those 72,000 nerves are going to tell you if something's not right. So, first, we want to know how big's the cornea? What's the horizontal visible iris diameter? What's the shape or curvature? We talk about irregular stigmatism. How symmetric or asymmetric is it? You need to know that so that you can understand how the contact's going to fit. What's the surface quality? Is it a dystrophy? Is it ocular surface disease? Is it some type of other condition that's causing what's going on? What's the clarity in the central cornea? Do they have some scarring? If they had a transplant, what's happening at the host corneal junction? If they've got a post-herpetic, how much scarring is there? Make sure you record that early. Endothelial cell counts are wonderful. We're hoping for greater than 1,000. At Academy 2 weeks ago, there were a number of studies that showed patients were still doing well with less than that. But obviously, endothelial cell counts make a big advantage for us if we know how healthy the endothelium is. Pachymetry is wonderfully important, just so you've got an idea of how much cornea you have to work with. Curvature, whether it be keratometry or topography, and then, of course, elevation. If you have the access to a tomographer, that'll give you even more confidence in the design that you've come up with to help that patient do well. Then you want to obviously know the location and magnitude of the curvature and elevation, creating that irregular astigmatism on the front of the eye. So I said I like to do diagnostic fitting. I think that's the most important way to do it. Yes, it can be done empirically, but let's talk about that. We want to know what the initial lens is going to be. We want the flat K, the average K, and the steep K readings as a guide. Because depending on the size of the lens, you'll want to try and make sure you're respectful of what K readings, what shape the cornea is initially. We use topography as an additional guide, and because obviously that's going to give us a wider area. Remember, a keratometer is through 3.1 millimeter, 2 points, averages out. It is a poor man's topographer, but if you've got a topographer, that's going to give you more help to know what the corneal shape is so you understand how the lens is going to position. Over refractions, we always do that. We want to know how stable is it? How clear is it? I like to use my retinoscope to check first and then do an over refraction with the patients. Fluorescein is critical. If you haven't gotten good with fluorescein pattern under a gas perm lens, you will, because that's going to tell you so much about how the lens is positioning and writing on the cornea's regular and irregular portions. You're going to record the position or centration because that way you can then work to make it better if it's not. You want a center of the cornea with a blink. That's going to give you the best vision. You want that lens to come back while you're looking at different gazes. So I always have them look to the left, come back and blink, and to the right, make sure it comes back to the center of the cornea. That'll give you the idea of what's going to happen in the real world. Of course, remember, if you've got high minus lenses, using lenticular designs are critical. So you have thinner edges in a minus, and of course, thicker edges in a plus. Many times the labs will do it automatically, but don't forget to ask, don't forget to specify it. So that way you have a lens that's more comfortable, positions better, and doesn't drop if the lid is going to help attach that. So diagnostic fitting, absolutely. Corneal coverage, how much is there? You want to make sure you cover it. How much? Well, ideally, you want the contact 1.5 to 2 millimeters smaller than the corneal diameter. So if the average cornea is 11.8, then yes, going to a 9.5 or a 10.0, you're falling right within that area to try and help people out. If they have irregular cornea in different ways, we'll talk about that as well. You want to make sure there's a good tear exchange on the blink. You don't want peripheral seal. You want to make sure that you're getting that tears coming in and going out. You want to make sure the line's on the eye. If it does that, then you're already part of the way there. And obviously, we want to minimize conjunctival staining. We don't want chalasis. We don't want 3/9 staining, even to the conjunctiva. We want a dynamic fit. It should move 1.5 to 2 millimeters on each blink. If it's got that movement, you know you're getting a smooth movement that lens in the center back where it's supposed to be. Remember, it moves along the steepest meridian. So obviously, understanding that will help you whether you've got with the rule or against the rule to try and help the lens stay put. I always measure the alignment with fluorescein because fluorescein will tell you exactly how much is in there. and you'll get really good at determining if it's a half diopter steep, if it's a half diopter flat, and then record that in the chart. If it is evenly distributed, that the force of the lens is going to be distributed even across the cornea. And that's very important with these irregular conditions. The mid-periphery region needs slight corneal touch for centration. If it doesn't, then we're going to have problems trying to keep that lens where it's centered on the eye. And of course, the central part needs some kind of slight apical clearance. We try not to touch the center of the cornea for obvious reasons. We'll talk about that here a little bit later. So how do we fit these lenses? Well, fitting spherical lenses, we strive for alignment fit on the cornea. That means if we avoid central bearing, we're going to decrease central corneal scarring. The quick study showed that apical touch scarred 31% of patients. Wow. So, and in the past, we would use apical touch. That was not a bad thing. And yet we started seeing this in our patients. And yet only 9% of steep fit with apical clearance show scarring. So how do we determine that? So obviously, if you increase the optical zone diameter, make it wider, you're going to increase the sagittal depth. Keep it off that center cornea. At the same point, if you decrease the optical zone diameter, you're going to decrease the sagittal depth, as shown in the red, and that's going to create this issue. How close is it getting? What about the peripheral curve? If you decrease the radius, you're going to increase the clearance. Kind of makes sense. Think about the anatomy of the lens. Same thing, if you steepen the peripheral curve radius, you're going to decrease that edge clearance. And your edge clearance becomes very important with these lenses. Obviously, if you increase the peripheral curve width, you're also going to increase that edge clearance. And if you decrease the peripheral curve width, you see in the red, that's going to decrease the edge clearance. So think about those three concepts. It makes a big difference. In fitting spherical lenses, we want to make a change and make it valuable. That means the base curve has to be increased by more than half a diopter. The diameter or optic zone needs to be increased by more than 0.3 millimeters. The change in center thickness should be more than 0.03 millimeters. The peripheral curve radius, at least a millimeter if you're going to try to do that, the radius of the curve. And of course, the curve width, you want to make sure it's more than 0.2 millimeters. And I've shown that in this diagram to try and help you understand the easiest way to make those things work. So what about back toric and bitoric lenses? Well, toric gas permeable lenses are not helpful with irregular corneal patients. Why? The refractive axis is different from the corneal axis. Bitoric designs have their base curve radar set with the powers 90 degrees apart. However, we do use them to help alignment, but it's not going to help vision. And so be aware of that as you're trying to make these spherical lenses work and you think, I'm just going to use a bitoric. There are a few conditions where we do that with, but remember, it's not going to correct the vision as much because the axes are so misaligned. So let's talk about the specific conditions that we all face and then put these patients in to try to help out. First is a map dot. So obviously, if you look at the picture on the right and you see those map dot figures, you know there's highs and lows elevation in the cornea. If you stain it, which we do for dry eye patients all the time, boy, those maps, elevations come right up at you. And depending on how central they are to the cornea, that's going to depend how much blur patients like this are going to get. I had a patient last week, my corneal surgeon, cataract surgeon brought a patient over and says, I don't know why he's not seeing very well. Would you put a gas perm lens on and see if it's his cornea after his cataract surgery or is something going on in the back of the eye? And sure enough, he was able to see almost 20/20 with the contact lens. And so we knew at that point, while the cataract surgery was helpful, we had to deal with the cornea as well. So important with map dot, we want to avoid lens bearing over areas of maps or fingerprints to prevent mechanical friction. Again, think what's happening. You've got these elevated areas. We want to avoid rubbing on top of those. And so the ability to do that is by making sure we get a nice wide area to make sure well, let me go back. I apologize. Good. So we want to make sure we want to fit that apical clearance over all those areas. And so that way the central cornea stays clear. And of course, using your peripheral curves, it work out great. You want to see a pattern of fluorescein that's even, and so that you're not touching any of those areas. If you are, we're going to steepen that base curve, change the overall diameter. What about the conditions where we've got herpetic corneal scarring. Well, obviously, we've got to figure out where that is and know that the cornea presents these abrupt zones of corneal regularity, creating local or diffuse topographic changes. This is where topography works is very, very helpful. Front surface toric lenses are often used when there's this large internal astigmatism, since the spherical lens will correct the corneal astigmatism, but many times there'll be this leftover power. So don't be frustrated because these are abrupt zones that they still have vision changes and need those front surface toric contact lenses. The cornea will have these residual depressions with pool fluorescein. The key is we don't want to have so much that we develop bubbles. We'll end up with some dimple veiling, and we certainly don't want to have to deal with that. Typically, a large lens design guided by topography, as I said, and help lens centration and perform better. And these we're talking about. And maybe depending upon how big cornea is, don't be afraid to go large with your herpes simplex keratitis scars over the center cornea. These patients and these ulcer patients will absolutely appreciate you more than most. So with heel corneal ulcers, there's a flattened area where the scar was, and that's going to affect centration. Depending on where the scar is on the cornea, it's going to have effect. And so healed ulcers with residual scarring, we try to minimize those bubbles just like we did with our post-herpetic. We want to decrease the dimple veil staining. Due to the asymmetric cornea contour, it's difficult to vault that affected area with a touch adjacent healthy cornea. So in these cases, that vault can be large and we'll have the adjacent cornea to be able to help stabilize it. We want to reach good vision with this lens with good centration, movement, and tear exchange. The lens will center of the steepest, most elevated axis of the cornea, which may be over the scar. Larger lenses, again, are going to help center better. So make sure as you're watching the fluorescein pattern, what's going to give you the coverage and give you the chance that we don't create some type of staining over that area. What about trauma? Much the same way. Trauma-induced irregularities, uncorrected by soft lenses, are well managed by gas perm lenses. No doubt about it. The alterations from that penetrating trauma will have a huge effect. And how well they sutured is going to have something to do with it too. So it's not only the area where it is, but it's the adjacent area that's not going to have this irregular astigmatism as well. Topography is critical with these. We want to determine the post-trauma corneal shape. You want to evaluate the fitting relationship with fluorescein centration. And you want to follow the same procedures as you would for a post-surgical patient who's had problems on their cornea. What about the large lenses? And these, again, 10 to 12s are most stable, vault over the regular cornea. For the base curve, start with the most regular part of the cornea and then work your way towards where the scar is. That's where topography becomes such a big help. What about grafts? We used to do a whole bunch of grafts. And so remember, the average time is usually 1 to 3 months after surgery, always after the inflammation subsides, always later. And so the surgeon is going to have to tell you when that is. These patients are anxious to get back to seeing. You want to know, how did it come out? You obviously want to have a clear graft. You want to make sure that the junction is clear. And the surgeon many times will leave those sutures in. They're not going to take them out sometimes for a year. And so at this point, you want to have the opportunity to help them and make sure you do well. These are important with reverse geometry lenses. You want to use a steeper base curve for better alignment. That way you have the ability to truly help keep that lens centered. It's got to be large. The optical zone's got to cover the graft. And so depending on how big a graft they use, you want to go outside that. Significant edge lifts is helpful. Get good tear exchange underneath there and make sure we're doing well. If you put the lens on and you see an exposed suture or an exposed knot, that's a referral back to the surgeon. We don't take those out in our office. We let them have a chance to do it. What if they get some of those sutures removed? Yes, it will change the corneal shape. So we always tell the patient, if your surgeon removes some of the sutures, which they'll usually do sequentially, please, I want you to return so we can ensure the lens is still fitting the new shape of your cornea and make sure it's doing the right thing. We use quadrant-specific designs for these tilted grafts if they're not even where they are. And, I love to say that the surgeons do a great job and get that regular. It's never. High decay materials are critical so we can keep that the host graft interface doing the right thing. Reflector, because the cornea is so irregular, and that can be done with your autorefractor or with the keratometer while they blink. So make sure you watch for that. And of course, we don't want staining at the graft host junction. If we do, we've got to vault over that area even more by fitting that peripheral curve even tighter. Post LASIK, PRK, and RK. I want to see better. I had surgery, so I didn't have to do this. I know. So we're going to need an oblate design. Reverse geometry curve is most helpful. Again, large diameter lenses to try and give the patient the coverage that they need. Reverse geometry lenses are designed with a flatter central optical zone compared to adjacent intermediate, which helps correct those post-surgical corneas, like RK or laser vision. And so it does manage the irregular astigmatism perfect by providing that more appropriate fit. So let's talk a little bit about these reverse geometry lenses. The defining feature is that central optical zone is flatter than a standard lens. The intermediate relief zone has the ability to help be surrounded by the steeper intermediate curve, and that gives that cornea more chance to move and regulate the lens fit. And of course, the alignment of the cornea on the central is important, especially on the irregular shaped cornea. And probably most important is that peripheral contour. They're designed to hug the unoperated on peripheral cornea. You want good tear exchange, overall stability, keep that lens centered. These patients are some of the most rewarding because they really want their vision to be clear without glasses. And the worst thing you can tell them is, okay, now you've got to wear glasses. Just doesn't make them very happy. What about corneal degenerations, ectasias? Yep, you can imagine how blurry this poor patient's seeing when they've got Salzman's. They certainly have the inability to get that focus in many of the parts of the cornea. And so what do we do for this? Obviously, they've got elevated subepithelial nodules, irregular astigmatism of every single one of them. And that irregular astigmatism is really disturbing. Gasperm's fit for that shape will many times need a bitoric design. Why? Because the nodules aren't all in the same place. And so a bitoric design, guided topography, or by fluorescein can really give this lens a better chance to stay stable. They're typically peripheral. They act as a barrier to lens movement. They can affect centration. So how do we work on that? We want to go to a smaller diameter lens. By staying clear of the nodules, avoid tissue breakdown discomfort, we'll do better. So these patients may be in an 8.0 or an 8.5 size lens, depending upon where the nodules are and how you keep it away from there. What about terrains? I told you I have a patient send to me, the doctor said I wouldn't touch that. And I'm telling you, it's very, very successful. Remember, they've got progressive thinning of the peripheral cornea. It stains like a gutter, and that causes irregular astigmatism. The topography on these patients is, for better lack of a term, wacky. No doubt about it. Large diameter lenses cover the pupil if the lens is decenter toward the steepest axis. Don't want far out, just rub on that area of demarcation between the terrain's marginal dystrophy. But obviously, you want to be large enough because the lens isn't going to center, but get it to do the best it can with. And we don't want staining, obviously, in the periphery, but you want to make sure it has that centration to make it do well. Pellucid is a less common, so we don't always see it exactly, but you'll see it on your slit lamp, excuse me, with your retinoscope. There's this arcuate band of thinning between 4 and 8, hence the kissing doves. The center cornea has a normal thickness. It does protrude forward, and that's what causes the irregular against the rule astigmatism. Luckily, against the rule, the lens is going to ride against that. But that butterfly pattern has this central against the rule bow tie, the inferior. So think about the anatomy of the lens and how am I going to make that work? Gasper lenses bitoric. They provide better vision to treat the corneal irregularity for improvement because it is so different inferior compared to superior. Keratoconus. So I put diagrams up so we can talk about the fit of the lens so we understand that. Corneal gasper lens is usually successful when there's less than 350 microns of corneal elevation difference along the greatest elevation of change. So that's critical. Yes, I fit keratoconics in gasper lenses, but not after we start getting so much variation that I can't get that lens to center well, or I've got so hard to make it have the fit that I want. So remember, the fitting velocities vary from apical bearing. That's the A picture. And so in the early days, we did try to press on the cone. We tried to create some pressure upon that to try and help out. And studies have shown you can actually flatten that center cornea, increase some of the thickness. But as you learn from a quick study, scarring is a real risk. We use 3-point touch in our office. We want a light bearing nasal and temporal, apex of the irregularity, and have some peripheral clearance. And that's what the picture is up there, B. That's your safest way to go. And studies have shown if you do a 3-point touch, you'll actually decrease some of the astigmatism irregular in the cornea. Wow, that'd be helpful. So when they take their contacts off, they actually do have a little better vision. So apical clearance is fine, but you got to find some way to get that lens to have a chance to center. Most of us believe bearing will create problems, so evaluate that with fluorescein, and you'll feel like you've got a good success going forward. So again, if there's less than 350, they work great. And so remember that a keratoconic cornea is an irregular prolate ellipse. And think of that in your head. How in the world can I put this into understanding? If you understand the shape of the cornea, then when you put the fluorescein under the lens, you'll see how it's doing. So I've got topography on the right, I've got the fluorescein pattern on the left. And if you understand topography, you're going to say, oh, I understand why there's touch there, why I've got pooling superior with actually a little bubble in there. And so cones are classified as central or nipple cone, inferior sagging oval cone. Most of mine, it seems like, are the inferior and they're sagging. And so remember that the lens is going to end up centering over that cone. Knowing the shape helps. An axial steep simulated Carey reading, that SimK, does provide you the apical clearance on the central cone. For an inferior cone, remember the peak of the apex provides the lens with minimal apical touch, and that's exactly what we work for each time. Center cones can be small with optical zones to match. Inferior cones need larger. And since most of mine are larger than inferior, they're going to get a larger diameter. Except some inferior decentration with inferior edge standoff, and patients tolerate that very well. Peripheral curves, important, wider and flatter. You want to increase the edge clearance, also prevents adherence to that lens on the eye. Back surface asphericity, helpful. You want to flatten more quickly to match the high eccentricity of the keratoconic cornea. What about post-surgical occlusion? Well, it's really weakening followed by refractive surgery, and that's causing that cornea to bulge. So we're going to fit this irregular astigmatism as if the patient is keratoconus. We'll fit them exactly the same way. Piggyback. Oh my goodness. So what if we put a soft lens on the cornea with a rigid lens on top? For patients who are having struggles, that soft lens really does cushion the cornea. It gives improved RGP centering and stability. In early days, people thought I was crazy. I said, it works. Even if there's a half diopter soft lens, it will improve the comfort. Remember, if they're post-arc or LASIK, what if you use a +6 to create a more normal curvature? What if you use for keratoconus a minus lens, a -3 or higher to increase centration of that lens? It works. It works really well. One thing we do is if we use a soft lens first, we'll get a topography on top of the soft lens. That way, now we know what the true corneal shape is with the soft lens on top. Remember that the soft lens aligns with the gas perm, the gas perm aligns with the soft lens. It avoids adherence and edge lift. Soft lens only contributes 20% of its power to the system. That really confused me early on. I'd put a -4 on there and it only gave me a small amount of power. So remember to confirm that with the over-refraction. I guess the bottom line is don't worry about the power. Oxygen transmission, obviously high decay gas perm lenses, as well as high decay soft lenses. In the ease, care, and cleaning, we just do hydrogen peroxide on both with separate cases. And that way people don't complain, well, this is so much to have to deal with. So probably the most important, Dr. Quinn talked about this last week, patient education. Teaching patients takes longer, requires patience about the insertion, removal, and hygiene. But if we take the time, it will improve compliance, proper use of the lenses. Opthane can be used to dispense if needed. Staff always asks me, they're not allowed to do that on their own. And remember that the cornea does desensitize, but the eyelid never does. And so knowing if you start with ophthalmine early on, it does give the patient the comfort of what it's going to feel like later. Eyelids, they do definitely have to get used to it. Not a callus like we told patients years ago. And we do increase gradual wearing time. 4 hours the first day, we increase 2 hours a day to try to help the patient. Sitting in a dark room works great. Looking down looks great. It's much easier when your lids don't feel the lens. I love my young patients that come in after a week and they got their head back like this. Mom says, "How come Bobby's a snob?" I said, "Because when you tilt your head back, you can't feel the contacts." And they all giggle. And I'm like, "Yeah, his nose will come down in the next week. It'll do great." Care and cleaning, we like, and I don't promote products, but the Boston Advance, if you try to research cleaners, there are not a lot of them out there that you can go find in the store. The Boston Conditioning also does a great job. We actually demonstrate and they show us how they clean that lens. I like digital. Some patients like the Q-tips fine. Do remember, some of our lenses today are so thin, you can evert that lens. So don't press so hard. Or if it's upside down in the case, I've had patients press on it and now it's inside out. It never goes back to its original shape. So do tell them to treat it carefully. We ring drops during wear. We do tell them to use the drop that says approved for gas burn lenses. Regular follow-ups, we always see them at a week. We expect to see their vision good, the comfort, still aware of what's going on. We then see them 2 weeks after that, so 3 weeks later, and by then they should be walking in with a smile, knowing everything's doing well. We wanted to figure out what's going on at each of those visits. We use fluorescein each time, check their vision, make sure the lens is staying clean. Obviously, long-term management. We want to make sure the lens stays centered. We want to make sure the vision correction is good. We need a company that can help us order new lenses if the lens power or adjustment needs to be made in the fit. We want that centration. We want the lens movement to be accurate. We want to reduce discomfort by that lens movement. If we can tuck it under the lid, we do that. And then we always address discomfort, poor vision, or decentration. We don't talk about piggyback right off, but that's when if the patient has a wonderful fitting lens and are just being very uncomfortable, that will then go to a piggyback. Patients will say, "Why don't I feel both? It's pushing out further." The soft lens is so thin, it does great. Obviously, the things we want to be careful of. A 3/9 staining, dryness peripherally, discomfort, any of those things. I say, "How are the lenses feeling? They're feeling so much better, doc. Thanks." Proactive management. You want to jump on things as soon as they happen. And don't be afraid of adjusting the lens type or fit. It can significantly enhance wear tolerance, reduce complications. Tell the patient, "I got this. We got this. We're going to make sure this is going to work out well." So why? We all know we can give people superior vision. We give them great corneal oxygenation benefits. Yes, we discuss the initial discomfort and adaptation because the rigid lens designed for them is something they're going to have to adjust to. And yet, we're going to also tell them that if you're careful, don't rub your eyes too much. Irregular corneas can cause displacement. And so we want to make sure we tell them how you rub your eyes. Make sure you rub down low. Don't get your knuckle involved to try and make a difference. Gas perm lenses are a huge part of our practice. They are alive and well, even for irregular corneas, for patients who want to see better, who want to take care of their visual needs with a lens that can truly outperform other lenses that they may have had a chance to try in the past. These are my references. And so the contact lenses are going to continue to evolve. I'm so glad you have an interest. I want to thank you for joining us tonight. Ariel, any questions that have come up, any things I can answer specific to irregular corneas and gas perm lenses?
Yes. Yes. So our Q&A was down. So if you guys have any questions, please go ahead and throw them in. We had a couple come in. One of the questions was, what replacement schedule would you recommend for the piggyback soft lens?
So we always try to use a daily wear if we can. If it's a price conscious thing, then we will use a monthly, but a daily wear lens, if you can get one steep enough. Remember, if you're dealing with a steep cornea, you've got to make sure there's no fluting of the lens edge. But we tell them a daily wear lens is the way to go. And for the most part, patients have been able to afford it.
Right. Then another question was, if you've been in practice for some time and would like to start fitting RGPs, where would you recommend we start?
So again, you need some fitting lenses. And so I would contact the lab that you use most for soft lenses and say, if I wanted to get some kind of fitting lenses, where would I do that with? As you know, the companies that are out there are available and they will give you a fitting set or sell you one for less money because I know you're going to be indebted to them to be able to go forward. And so if you're uncertain, obviously, Tyler's Quarterly does well. You go on OD Specs, find out what labs are out there. I promise you, you've heard of these labs. They all do a great job. And the consultants are great too. They really want to help you be succeed.
Then, what are your thoughts on using tap water to rinse RGPs?
Um, I, it, I'm the old-fashioned guy. Tap water's fine. The
Mhm.
biggest worry, remember, if they've got a corneal abrasion and you put that in there, that's an issue. But we've used tap water from the beginning, and we've never had an issue. I've never had a corneal ulcer from gas burn lenses ever. And so, in my opinion, it truly is my opinion. Everybody else is going to say use sterile saline, and that's fine. But gas sperm lenses tolerate tap water very, very well.
What about the old rinse of the mouth and put it back in?
So I had a patient last year. He had it in his mouth doing that. And a friend came behind and said, "How you doing, buddy?" He swallowed it, and he had to tell me.
Oh
He says, "You've been telling me
no.
forever." And so that's the most vile thing I've ever heard. My brother's a dentist. He says the mouth's the dirtiest place in the body. And so please, please tell him don't do that. And they said, "Well, I'm out, and there's no other liquid around." I said, I don't care. Don't take it out and do that. You know, you can push it onto the conjunctiva and it doesn't hurt. Leave it there and you can get some water. My goodness gracious. Yeah, no, 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 never, ever, ever. Patients tell me they do it and I just want to throw up. I just got
Um, would you ever consider referring a like a MAP doc patient for like a scrape before fitting a GP
I do not.
department?
I've got a corneal expert in the office, corneal fellowship trained, and as long as I don't touch those maps, I am fine. The patient doesn't know what they don't know. I can see them. I show them a little. I say, "This is what you got," but I've never had to go to that extent.
Okay, great. And then another question was, when do you know that a GP is just not going to work and you need to go to a scleral lens?
Well,
Um,
obviously, if the toricity of the cornea is very high, if I cannot get that lens to center, then I will tell a patient, you know, the vision you can get with that lens when it's in front of your cornea, in front of your pupil. We need to find a lens that's going to stay there. It's going to be able to do the right thing. And so we've actually put patients in sclerals who then had some kind of problem with the insertion removal with the liquid. And so Karen, we refer them back to me. I'd put them in the gas sperm lenses, and they'd say, "But these lenses move." I said, "Yeah, when they blink, they move." They said, "I want to go back to my scleral because they don't move." And so centration is huge. Remember, they're looking through the optical zone of the lens. So if I can't get it to center with all of my skill with peripheral curves and understanding that eccentricity values, and I can't get it because the cornea just is not cooperating, and I blame the patient. I don't blame me, then a scleral lens is going to give them that non-movement, consistent vision to make them give them what they want without having all the action of the lens.